We are planning a program for Sunday, that is 28th of June. I mentioned to you, there is a lady from New York. Her name is Mona Johar. She will talk on nutrition. And then I will send you an email or WhatsApp. Then we plan this activity on 28th. I hope you are available on 28th.
Yeah, it should be okay. 28th should be okay.
Thank you.
Sandeep? Hi, Sandeep. Sandeep?
Yeah, ma'am, he's there, ma'am. Yeah, he's there, ma'am. He's just joining. Yeah, he's there, ma'am. He's just joining.
Yeah, Miss Vandana, tell me. Yeah. Hello? Hello?
Can you just check sir's signal?
Yeah, we have already checked it. It is coming good. As of now, good. It's good.
Okay.
It's good. Okay. Yes. Shardul, there is some echo coming. Please check it. Echo coming. Please check it. Echo coming. Please check it. Echo coming. Please check it.
That is basically that echo is from Vandana ma'am. But she will be not part of the conference, right? So I am muted her now and there is no echo.
Is there any echo now? नहीं आ रहा. ठीक है. Okay.
Recording has started.
यार ये श्री शेरे मठ का तो सिग्नल ऊपर नीचे जा रहा है.
Dr. Parikh has joined.
Good evening, sir. Good evening, doctor. Dr. Chopra, can you hear me?
Dr. Parikh, good evening. Sandeep here, sir. The slides will be run from the back end. So I'll just run the slides. आपका सिग्नल तो बराबर ही आ रहा है. Shardul, can you do a voice testing? फिर मैं स्क्रीन टेस्ट कर देता हूँ.
Yes.
Hello.
Dr. Parikh, can you say one or two lines, please, for audio test?
Yeah, good evening. Welcome, Dr. Chopra, Dr. Naveen Nanda. Dr. Hiramat is not yet joined, I think.
Okay, sir. Okay, sir. Your voice is okay. No problem. Signals are also
Sequence, sequence, I will introduce Dr. Chopra, and Dr. Chopra, you will introduce other speakers.
Okay, so introduction slide, who will play? Should I play the introduction slides or like how does it go about?
Yeah, you can,
When my introduction is over, I'll take over and I'll introduce first Naveen Sinanda, introduce the topic. At that time we keep on showing, introduce, complete it, and then I'll go to Pyramid, introduce him, and just a brief I'll introduce to Dr. Anil Parikh also. All the three people will be introduced by me. You can keep on showing their brief.
ठीक है, I'll do that, sir.
Sandeep, I will first introduce Dr. Chopra and then hand over to him.
हाँ sir. एक बार I'm just running the slides for my this thing. So this is Dr. Chopra, then Dr. Naveen C. Nanda, then we have Dr. Shirish and Siramat. That's it. Fair enough, sir. Yes. All set. Dr. Hiramat joins, then we are set perfect.
Who is this person who is saying this?
From the admin side.
Dr. Hiramat, are you there? Hello?
Sandeep,
Yeah.
he's coming in 10,
Yeah.
3-4
Okay.
minutes. He's coming in 10.
ठीक है, okay.
Chopra, can we ask you your views on the Lancet and NEJM articles? Can I ask you the views on Lancet and NEJM articles being retracted?
See, according to me, the ICMR is very firm. They are not changing their stand at all. The Lancet tried to bring in some issues. They were critically analyzed. WHO also is readdressing it. I think there is any call of any concern. It's basically spoken very well by Valeria. I have sent to you the details. One of the news, I think, NDTV, and he mentioned that the cause of high death rate was that the selection of cases was not proper. They took those patients who were elderly. Number two, they did not analyze their EKG. Is the late admission. People who came late. When they come late, the myocardium is affected by the virus. So what is the role of hydroxychloroquine? And he also mentioned that the hydroxychloroquine has been used for a long time by me. He mentioned.
The question is whether the patients are there or not there.
Huh?
Whether the patients are there, first of all.
So that's a big point. That's a big point. I think he told it stood the test of time. They had been used hydroxychloroquine for a long time. Even we use in a lot of patients who are young. Except those who have CKD
I don't do
or
much
there is a
work in-
conduction defects.
I don't do much work. Although I'm based in South Delhi.
So there is no problem. I don't foresee any problem. It is just a minor controversy, and I mentioned to you there will be spontaneous consensus very soon. It will become spontaneous.
Yeah, I can do that. Yeah.
You see the wave already. We are already using a lot of our patients in the hospital, in the emergency, treatment in isolation. Everybody is given hydroxychloroquine. Those who are less than 55, those who are more than 10. Every patient, as a protocol, we give 400 BD and 400 OD for 5 days along with azithromycin, vitamin C. We also give zinc in this patient.
What's your experience?
Patients
What's your experience of this treatment?
excellent drug.
Oh,
There's no doubt about it. I think, though I am not treating any COVID patients, but my colleagues tell me the information.
Do you give it along with zinc?
If a person has got a multi-organ failure, we can't blame TQS for that. It's a multi-organ failure because of viral disease. So there is a misinterpretation in the Lancet, which is very highly debatable. Hi, Shirish, how are you? Good evening. Shirish, can you hear me? Shirish Hiramat?
I think it's not able to hear.
Mic is muted, sir.
Very relevant.
We can hear you, Dr. Hiramat.
Dr. Hiramat, can you speak something? Hello? Shardul, just quickly उनका computer एक बार take over करके करते ना. We are sending you a request, sir. Please accept it.
Thank you, dear. Thank you for taking.
Hello. हाँ. हाँ. Yes, yes. अभी
You know what I feel, Anil? You can
not able to hear where.
you can prepare some document for copy. You can prepare some document for copy. You can prepare some document for.
हाँ सर आपका ना पिन अप हो गया है. आप लॉग आउट कर लॉग इन करिए. आपको पिन का साइन दिखा रहा है. वो सब पिन हो गया है आपका ब्लू जीन्स. आप लॉग इन करके लॉग आउट कर लीजिए. लॉग आउट करके लॉग इन कर लीजिए सर. ओके.
Just feel everyone needs
हेलो.
who are less than contribute.
Shardul, have you sent the request?
Least I can do is contribute.
शार्दुल उनका रिक्वेस्ट लेके वो कर देना है.
कुणाल मेरा पिन कोड इस पे चलन मेरा पिन कोड थैंक यू.
Hello.
ठीक चल रहा है, चैट ठीक चल रहा है, पेमेंट ठीक चल रहा है, कम चल रहा है, पेमेंट ठीक चल रहा है, कम चल रहा है.
नहीं वो उसका सबका ले रहा होता. हाँ तो मैं निकलूँ क्या यहाँ से, क्या करूँ? हाँ तो मैं निकलूँ क्या यहाँ से, क्या करूँ? वीडियो. हाँ तो मैं निकलूँ.
बैठा
Dr. Hiramat, can you speak something now?
Yes. Good evening, everybody, and
Yeah.
good morning to Dr. Nanda.
fair enough, sir. We are able to see your screen. Sir, can you do one thing? एक बार quickly आप screen share करेंगे, sir? On the top mic के बगल में there is a screen share option. Just click on that and click the first button. Click here to start sharing screen.
Are you able to see my screen?
Yeah, Dr. Sirish MS Hiramat. Sir, slide show में लेके एक दो slide run कर दीजिए. We will get a good idea about it.
Yes.
Run, yeah, fair enough. ठीक है sir, you can do stop sharing. And now we have 2 minutes to go live. I am just starting the live. Then exactly at 7:30 we will start. I'll give you the cue and share my PPT immediately.
So Dr. Chopra, what is the sequence? Dr. Nanda first, you next, and then I'm there, right?
And then you'll be speaking third, because my and Nanda topic are almost identical.
Yes.
And then you come
Yes.
back.
Yeah, they are good together, I mean, in continuity.
Okay, he's covering only atrial fibrillation echo. I'll be covering echo validation of NOAC. So it is the same pattern. And then comes, of course, the CAD, comprehensive preventive strategies, which we will discuss by you. And then we'll have a discussion in the last.
Yeah.
I'm very happy. This is our third series together.
Yeah. I think after we exchanged some messages on the first one,
It's great. I'm lucky.
we have come back to back.
Lucky to be together with you.
Yeah.
Great. I think we'll have many more platforms together.
Sir, it is 7:30. We are starting now. I am just sharing my screen.
Sandeep, I can start.
Start, sir.
Yeah. Good evening. I am Dr. Anil Parikh, President Medical Affairs and Clinical Research, Ipca. It's a great pleasure for me to welcome all doctors across the country who have logged in for this Experts Outlook webinar series on atrial fibrillation and on coronary artery disease prevention. And we have a galaxy of experts for this webinar today. I think we have the living legend, Professor Naveen Nanda on echocardiography. We have Professor H.K. Chopra, and also we have Dr. Sirish Hiramat. So I would, this is going to be presided over, moderated by Dr. H.K. Chopra. So I would like to first introduce Dr. H.K. Chopra. He's a Chief Consultant Cardiologist at Mulchand Medicity Hospital, New Delhi. And he has held various positions at CSI and various, forums across the country. He was National President of CSI in 2015, National President of Indian Academy of Echocardiography 2017, Country Head AHA, American Heart Association 2015 to 19, Chief Editor, the various journal AIHF, ACC, Indian Edition, CID Update and STEMI, Atrial Fibrillation Update, IHJ, and President Wellness Foundation, New Delhi. And above all, he's a very close friend, and always whenever we request him for CMEs, he always obliges us and takes a valuable time. So it's a great pleasure to welcome Dr. H.K. Chopra. Dr. H.K. Chopra, kindly take over. It's all yours now to moderate from now onwards.
Thank you very much, Dr. Anil Parikh, for your kind words. Dear friends, ladies and gentlemen, it's really a great pleasure and honor indeed for me to be here on the platform of Experts Outlook webinar series, Ipca Cardio, on the occasion of a very prestigious global webinar, Clinico-Echo Dialogue. Two important subjects are covered in this dialogue. First is on atrial fibrillation, where very eminent faculty led by Professor Naveen C. Nanda, who is the world father of echocardiography, talking on echo evaluation of atrial fibrillation. And subsequently, I'll be talking on NOAC and echo validation, how we validate the usefulness of NOAC in our practice today. And following me is Dr. Shirish M.S. Hiramat, who will be talking on CAD, comprehensive prevention strategies. I think it's going to be a very, very interesting talk. As you all know, that in India, the CAD is growing. The details of scenario will be spoken by Dr. Shirish Hiramat. But I can tell you, the prevalence of atrial fibrillation is also very, very high. It is up to a tune of 2 to 10%, very high. As the age advances, we see the high prevalence of atrial fibrillation and its related morbidity, which we shall be discussing in the next few minutes. The only question is, which patient to be identified and how should be identified? Who should be given NOAC? Besides CHAD square or CHAD West square, which we discuss many times, and I think most of them are usually due after the age of 60. But from my point of view, the echo validation is the cornerstone of atrial fibrillation management, which should be mentioned to every one of you. Comprehensive CAD prevention is a very, very important subject, which will be covered by Shirish Hiramat. Now, my duty is to introduce the very eminent speakers, and it's not easy to introduce a person like Professor Naveen C. Nanda. It's a real Herculean and a tough task to introduce my own teacher. Whatever I learned in echo, in India and in the world, I bow in front of Dr. Naveen C. Nanda, who is my real guru and real teacher. He is a face of echo in the world. He is a distinguished professor of cardiology in the University of Alabama at Birmingham, a world father of echo. He was recently bestowed upon Icon of the Century in Echocardiography and Cardiology by the Minister of Health, Government of India and Department of Science and Technology just last year. He is a real legend in the field of echocardiography, a researcher par excellence and a teacher of teachers. He has contributed many books and many research articles, original articles, to his credit, and recipient of various national and international awards. I welcome you, Professor Naveen C. Nanda, sir. We have with us Dr. Shirish Hiramat, who is also a very, very eminent person. And I think this is my third webinar series we are together. And he is the director of the Cath Lab, Ruby Hall, and is also the former president of CSI in 2017. And he was the convener of CSI NIC 2004 to 2006. He proctored many interventional cardiologists. He is an interventional cardiologist par excellence, and beside that, he is a very, very nice clinical cardiologist. And he has a tremendous interest in the peripheral as well as carotid and peripheral vascular interventions, and also participated in various groundbreaking trials. He is also a legend in cardiology and is going to cover a very important subject in India, the preventive strategies, what exactly we should do. So without wasting any time, ladies and gentlemen, I'll request Professor Naveen C. Nanda to have his presentation on echo evaluation in atrial fibrillation. Professor Naveen C. Nanda, sir.
Thank you very much. Let me get my presentation on. Okay. Well, thank you very much, Dr. Professor Chopra, and it's really for your very kind words. It's really a great pleasure to have you on this panel. And as you may not know, that Dr. Chopra had did some pioneering work on echo assessment of the tricuspid valve, which is many years ago. which has been very valid now and has been quoted extensively on that work. As you know, we are getting more and more interested in the tricuspid valve, which appeared to be a forgotten valve, but there's more interest now in that valve, and his work is really very much quoted. As far as the topic today, see, I don't think I can advance my slides. Unless you can do that. Okay. When it comes to echo assessment of atrial fibrillation, echo is very, very important because what it can do, it can look at all the chamber sizes, both atria, both ventricles. One can look at mitral valve abnormalities, which can cause atrial fibrillation, like mitral stenosis. Looks at annulus calcification, which is also a risk factor for atrial fibrillation, carotid as well as aortic atheroma, another risk factor for atrial fibrillation. One can look at the PFO, patent foramen ovale, which can actually facilitate thrombi in the right atrium going into the left side of the heart. One can look at the pulmonary vein anatomy, very important when it comes to ablation of atrial fibrillation. Hypertensive heart disease, of course, looking at left ventricular hypertrophy, which again, as you know, is a marker of hypertension and cardiovascular involvement, as well as looking at mitral regurgitation, which can be caused by atrial fibrillation itself. Important thing to remember is there is something like an atrial cardiomyopathy, where actually there may be changes in the endothelium of the left atrial appendage, which actually facilitates the development of thrombi and platelet aggregation. And obviously, when we go on the echocardiogram, we want to look at both the atria and both the appendages for smoke, which is a precursor for thrombus formation, as well as sludge, which is something in between, and then, of course, thrombus. And these are due to not only changes in the atrial endothelium, but also because of stasis, because of reduced blood flow velocity in the atrium and the atrial appendage, also due to left atrial enlargement. And then one of the things we look at is the Doppler of the mitral valve, and if the velocity is less than 20 centimeters per second, that is again one of the markers for stasis development in the atrium. Not only that, we could look at this with the two-dimensional and three-dimensional transthoracic echocardiography, transesophageal echocardiography, and once in a while we also use contrast to detect thrombus and differentiate that from pectinate muscles. And one also remembers that if you tend to have less thrombus if there is associated mitral regurgitation, because that increases the flow state in the atrium. One of the very important things to remember is that 1/3 of patients with severe mitral stenosis, they will have actually left atrial or left atrial appendage thrombus, and it may take actually up to 6 months for it to disappear after anticoagulation therapy, and I'm sure Dr. Chopra will discuss more on that. Doppler mitral valve A wave actually may not return to normal after cardioversion or ablation till at least about 3 months after that procedure, and which we call as left atrial stunning. So again, very important implication for anticoagulant use even after the patient has returned to normal sinus rhythm for at least 3 or 4 months. When it comes to one of the ways to look at the left atrial enlargement, we used to look at the diameter of the left atrium in the parasternal long axis view, but now we have gone into LA volumes, and we can look at LA volumes by 2D as well as three-dimensional transthoracic echocardiography. The maximum LA volume by transthoracic echocardiography is about 35 cc's or 35 mil per meter square, and the minimum volume is about 14 mils per meter square. And one has to remember that 3D TT actually gives larger volumes, which correlate much better with magnetic resonance imaging. So if you are going to calculate the volume, we do it routinely by 2D echo, but if you want to be more accurate, then we need to go with three-dimensional echocardiography. And of course, this also means you can calculate the emptying fraction, or you can calculate the left atrial ejection fraction, which actually, if you subtract the minimum volume from the maximum volume, will come out to be about 58 or 59%. So that is the normal left atrial ejection fraction. So these are some of the things to remember. Next, we want to go also into the newer technique of speckle tracking echocardiography. And there actually one can look at two things. If you look at the top here, where I got my arrow here, you have minimal volume here because of the atrial contraction following the P wave of the electrocardiogram, which is below here. And then, of course, there is systole, and during systole, the left atrium fills with blood, and that is the reservoir component of the left atrium. And then as soon as the mitral valve opens, that blood actually moves down, flows down into the ventricle, so that is the conduit phase here. And then you have the pre-A here, stasis in the left atrium here. So we have basically three actually functions of the left atrium. There is a reservoir component, there is a conduit component, and there is a contractile component. And you can actually calculate the speckle tracking echocardiogram with the myocardial deformation, the deformation of the atrium during all these three phases, and those are very important to look at also. So here, for example, if you look at the atrial contraction, of course the atrium becomes smaller there, so it is actually put below the baseline, as you can see here on the left side, and here also on the right side, negative here. And then of course as the atrium fills up, the atrium becomes larger, and therefore is plotted actually above the baseline. So when we call that something like minus atrial contractile, it doesn't mean really minus, it simply means it's below the baseline. So that's very important to remember. So these are the three components of the atrium that we actually look at. If you look at the strain values now, strain simply means deformation of the myocardium. There is change in the character of the myocardium, size and shape of the myocardium of the atrium. And if you look at that, if the reservoir function, the normal strain volumes are around 40, mean volume 40%, conduit is actually 27%, and contractile is 15%, but we call it minus 15%, because it's plotted below the baseline. It's not an algebraic baseline minus, but simply it's plotted below the baseline. So these are the normal values for speckle, using speckle tracking echocardiography. Now what is the importance of this? If you look at the decrease in L reservoir, which actually correlates very well with fibrosis on the magnetic resonance imaging, and you look at the conduit strain, the strain in the, as the atrium blood flows from the atrium into the ventricle, that occurs in the early stage of LV diastolic dysfunction. So actually sometimes you can actually, before actually see the changes in LV diastolic dysfunction from the ventricle, you can pick up those changes by looking at the atrium. And of course, in hypertensive heart disease, in hypertension, decrease in contractile strain occurs later because it correlates with decrease in the LV myocardial contractility and increased filling pressure. So what is the importance of all this? If you look at the low LA emptying fraction or expansion index and look at the left atrial global longitudinal strain, what I was talking about was the global longitudinal strain, that correlates with the development of stroke. And also in patients with mild hypertension and atrial fibrillation, reservoir and conduit strain, but not the contractile strain, they are lower in those with more severe form LV diastolic dysfunction. And one not only should look at the left atrium, but in atrial fibrillation, look at the right atrium also, because you have decrease in right atrium and right ventricular function also in patients with heart failure with preserved ejection fraction. Well, one of the cutoff values for recurrence, now what about atrial fibrillation recurrence? Where is echo useful? The cutoff values for atrial fibrillation recurrence by 1 year, if you look at the mitral E to A, if the mitral E to A ratio is more than 2.2, or if the mitral E to E prime ratio is more than 9.17, these have got a sensitivity and specificity of around 72% for recurrence of atrial fibrillation. Also remember that decrease in LA reservoir strain is associated with conversion from paroxysmal to persistent atrial fibrillation. And if you look at the atrial asynchrony, in other words, you look at different walls of the atrium and what is really the delay in contraction of those walls of the atrium, which is the standard deviation of time to peak strain in a sort of a 6-segment LA model, then that is an independent predictor for atrial fibrillation recurrence. Also, some studies have shown that if you look at the peak left atrial global strain, and if it is less than 10.75%, that predicts AF recurrence at 6 months. So echo is very useful in looking at some of these things. Now, of course, these are very individual studies. They may need further validation, but they are still very useful clinically to get some idea about which patients will actually have recurrence of atrial fibrillation and which patients with atrial fibrillation may develop some complications like cardiovascular problems or actually stroke. One just aside here, we also know that South Asians, especially in India, they're less prone to atrial fibrillation because the left atrial size is smaller than in the Western population. One quick word about atrial fibrillation causing functional mitral regurgitation. This is a subject which is really very much recently discussed. And what happens is that in normally the atrial, if you look at the mitral annulus, that actually becomes deeper, the saddle shape becomes deeper actually with during systole as well as during atrial contraction. But if you look at the in patients with atrial fibrillation, this actually annulus becomes larger. There is a decrease in LV globular strain, and also the annulus becomes flatter. So this atrial regurgitation, the mitral regurgitation due to atrial fibrillation, is not only caused by a problem with the atrium, but also problem with the ventricle. So the annulus changes its shape, so the annulus becomes more ventriculogenic rather than atriogenic, and this is what causes a functional mitral regurgitation. Just to show you, there's an interdependence of the left atrium with the left ventricle in atrial fibrillation here. Okay, now let's go by what we use clinically, how we look at echocardiogram to look at the left atrium and left atrial appendage. Of course, the first thing you do is to go for a transthoracic echocardiogram, two-dimensional transthoracic echocardiography. And here you actually can see the short axis view is sometimes very useful. Look at the left aortic short axis view or the left ventricular short axis view, and then one can actually see the left atrial appendage as well as the left atrium very well, and you might be able to see a clot in any of these structures. Not only that, which is neglected a lot, you can go by apical view, and as you know, the atrium is an anterior structure, so once you go from apical 4th chamber to apical 2 chamber view, somewhere in between, you will be able to see the left atrium, like in this here, showing by this arrow here, you can see that very, very well. And these are all, some of the pictures are from Dr. Hoyt, from our book on comprehensive textbook of echocardiography. So here is the left atrium. So one can look at the left atrial appendage by 2D echocardiography also in patients with good cardiac windows. And this is just a movie to show again. I'll play that again. Here is the left atrium with my arrow is right at the place where the left atrial appendage is, and you can see the left atrium very well. So transthoracic echo is the first thing you do. Of course, as you know, patients have poor windows, and you may not be able to see the atrium appendage very well on the transthoracic echo. So many times we'll go for two-dimensional transesophageal echocardiography, and there again you can see the appendage sometimes even more clearly. For example, here you have the left ventricle here, on the top is the left atrium, and then you can see the appendage very clearly here, shown by the arrow also. So if there is any clot there or any smoke or sludge, one would be able to see the appendage very clearly. If there is smoke, usually it's not a contraindication for cardioversion or ablation, but if there is a sludge, which means a partial thrombus or real thrombus, then of course it becomes a contraindication for these two procedures. Just to show that once in a while you can see the lobes of the appendage also with the two-dimensional transesophageal echocardiography. Also this is much better seen by three-dimensional echocardiography. Is a patient with pericardial effusion, and one can see all the three lobes of the appendage, left atrial appendage, very well in this particular picture here. And of course, very important, you look for thrombus, and here is a picture of aortic short axis view, and here is the smoke that you see. You'll be able to see it much better if it was moving, and you have a clot in the left atrial appendage. Now, the important thing here is that when you give this patient oral anticoagulant, the clot actually starts to disappear from the middle, somewhere in the middle of the appendage. When you give thrombolytic therapy, the clot dissolves from outside. But when you give them oral anticoagulants, the clot dissolves from inside here. So one of the ways to look for example, here you can see this, there's a black area here, dark area here, and there's another dark area here. So this shows there's lysis. Now naturally, even if you don't give clots, the natural agents in the blood actually would try to dissolve the clot, and of course if you give anticoagulant therapy, that facilitates that even more, and the clot, but it dissolves from inside. So once in a while, on the 2D echo, if you don't see any lysis at all, you can do a three-dimensional echo, and if you cut the clot, you might be able to see the lysis. So that gives you an idea that the clot is dissolving. That's a very important thing to look for, whether there's any dissolution of the clot or not. This is just to show a movie here, and I think I'll be able to play that. And here is a patient, we're doing it in the operating room, and we can see a nice clot here in the left atrial appendage. And of course, we're thinking whether we should whether they should take out this clot or not, and the surgeon thought it's a small clot, and he was doing a cardiac coronary artery bypass in this patient. Maybe he should not open the heart, because you can do the bypass without opening the ventricle. And then what happens, while we are actually discussing all this, the clot has its own mind, and you'll see, I saw, before I took out the probe, I saw something here, and then I saw the clot come right through that, and then go into the aorta here. So here is the clot embolization here. So again, remember that this, just to show this a real-time thing, where we could see the clot embolizing with our own eyes as we are doing the echocardiogram, and of course the clots can embolize. So very important to look at these clots and treat them, because embolization very common, can lead to disastrous consequences. For example, something like stroke here, and here you can actually see a very large clot. Now look at it, it's much bigger than what we saw there before. And why we didn't pick up this large clot? We picked up only a small component, something like a thumbnail, while the clot is much bigger here. And if you look at the aorta here, you'll see that embolize through the aorta into the whole body. The reason is we are not doing a three-dimensional echo. If we did a three-dimensional echo, the whole atrium would have been enclosed in the data set, and we would be able to see the clot itself. So three-dimensional echo becomes very important. This actually movie is to introduce you to the fact that three-dimensional echo becomes very, very important. Both three-dimensional transthoracic as well three-dimensional transesophageal echo are very important to look at the real size of the clot, and not even miss a clot sometimes. Because when you do a 2D echo, it's simply a slice technique, and depending on where you're taking the slide, you can even miss a clot, or you may actually underestimate the size of the clot. So here is a slow motion of the clot, and if you look at the aorta here, you'll see the clot actually moving into the ascending aorta very easily here. Right here, you can see that right here. Luckily in this patient, there was no stroke, but the clot was found in the iliac arteries, and I think they were able to go there down there, actually in the femoral artery, go into the femoral artery and take that clot out. And so this is just to show you about the clot here. So next is that three-dimensional echo. So here is a patient we're doing a three-dimensional echo. We saw something like a clot in the 2D echo, but we wanted to double check it and see whether there's any lysis or not. So here we have the aorta. Here is the left atrial appendage. There's a clot here, and then what we did, we tried to this. So this is 2D echo. We grabbed into three-dimensional echo, and you can see this large clot here. And then we try to cut the clot. When we cut the clot, there is no lysis here. So this is actually a fresh clot, has no lysis in it at all. So that's very, very important to get an idea that this clot is probably not dissolving, and maybe you need to be a little more, a little more aggressive in giving oral anticoagulant therapy. So here is a movie to show you how we can cut the clot. So here is in 3D, and I think it'll come up. Hopefully it'll come up now if I can play the movie. But you'll be able to see if the movie played. Sometimes it doesn't play very well, but if the movie played, go back to PowerPoint here. Then we'll go to the slides. This is always the problem with whenever trying to play movies. But anyhow, I think we can. But it just shows you if you cut the clot, you can cut the clot and get an idea whether the clot is dissolving or not, whether there's any lytic component to that clot, which becomes very, very important. I think you might be able to see it now here. So here it is. We have gone to the clot in 3D here. Now we'll cut the clot. See, I'm coming down from the top, and I can cut it at will, and then I anfas it, and I can take a look at the clot here. So this is just to give you an idea about the clot. Here is actually an attorney who came in once in a while, and we did a 2D echo. We didn't see anything, but when we did a three-dimensional transthoracic echo, we saw a clot, and I could make a diagnosis because right in the clot, I don't know whether you can see that from far, but here is a sort of a lytic area here. So we gave him anticoagulants, came back 6 weeks later, and the clot had disappeared, and we were able to actually send him for ablation for atrial fibrillation. Once in a while on the transesophageal echo, 2D echo, we actually saw something like a little clot here, but when we went for three-dimensional transthoracic echo, we could see that these are all actually pectinate muscles in the left atrial appendage, and the patient did not actually have any clot. So here is actually a comparison of three-dimensional transthoracic echocardiography versus two-dimensional transesophageal echocardiography, and if the window is good, then the three-dimensional transthoracic echocardiography has similar accuracy to two-dimensional transesophageal echocardiography. So we should always do actually a two-dimensional transthoracic echo, then do a three-dimensional transthoracic echo, and then of course later on if we find still there's a problem, we can go into two-dimensional transesophageal echocardiography. Now when you go for two-dimensional transesophageal echocardiography, it's also very important to do a three-dimensional transesophageal echocardiography. And these two actually show the same thing what I mentioned to you here. So I won't go more into these slides here. Now let's go into three-dimensional transesophageal echocardiography. What is the advantage? The advantage is you can look actually the lobes of the appendage very well. Here is a left atrial appendage, and you can see there are three lobes. You can look at the shape of the appendage and the lobes of the appendage, and more definitive that you are not missing a clot, which you can miss easily when you do actually a two-dimensional transesophageal echocardiography. Here we are looking at left atrium, mitral valve, and you can see the clots. In addition to the clot being in the appendage here, right here, showing my hand here, and then if you go into this here, you can see the clot is outside the appendage also. And then in the body of the left atrium. So sometimes if you see one clot, make sure you look at other parts of the left atrium to make sure there are no other clots there. And here again, looking at the top of the clot here in the left atrial body, this is all by three-dimensional transesophageal echocardiography. Just to expand one of these, so here we can look at the mitral valve here, there's the aortic valve, and here is the whole of the left atrium, and then you can see a large clot with the stasis, flow stasis here adjacent to it. Here this shows you movie how the clots look like. There's something like a jelly-like, and you can see that I think the movie can show you very clearly that there's something like a jelly-like clot here, and you can see it kind of vibrates a little bit, and not only the multiple clots here, if you can see this movie here, one second as well as a third clot right on the top here. One other important thing when you look at the left atrium, also look at the atrial septal pouch. Atrial septal pouch is simply, this is a septum secundum and septum primum, and there is a little area here which is low flow state here and come on the atrial side here, as well as can come on the left atrial side here, on the right atrial side here, and sometimes you can have two pouches like that from the left atrial side and two pouches from the right atrial side also. So these pouches are important to detect because you can see clots in them. Here, for example, one patient with atrial fibrillation, and we are looking at this clot here. You can see the area of lysis there, so it's getting some dissolution here. Here is a clot here, but then when we look carefully, it was actually in the left atrial septal pouch, and you can see in three-dimensional echocardiogram, you can see very well the clot will look like exactly the same what the surgeon would find, or if he were operating. It's a very similar picture of the clot. And here you can actually not only look at the volume of the clot also. That is very important also in three-dimensional echocardiogram. You can look at volume. So you can look at the volume of the clot in the left atrium. And when you look at dissolution of clot, it's much more important to look at these changes in the volume of the clot rather than looking at changes in the dimensions, which may not give you a good idea about how the clot is dissolving or how much it has dissolved. Not only that, I'll make a point here that when we can look at the volume of the left atrium also by three-dimensional echocardiography using the same technique, 3D echocardiography. The volume calculation is another important aspect. And here is actually the volume of the thrombus in the left atrium in this patient was actually 3 cc's. Here is another patient who says, where is the clot here? Here is the left atrial appendage, but the clot seems to be maybe outside the appendage, maybe it's inside the lobe of the appendage. And what I did when you look at this here, this patient MRI was done, thought he was having a clot somewhere around the appendage. So he was put on anticoagulant for 3 months. Nothing happened. So I said, well, I did another T on this patient. Let's look what's happening. So if you look at the movie here, what's happening is that this is no longer a clot. It's actually a lobe of the appendage where you're cutting it from the top. So it gives an impression that there is a clot there, but there's no clot here. It's really part of the lobe of the left atrial appendage. So very important to all these things. You can make a lot of mistakes on 2D echocardiography if you're not very careful here. So here what looks like a mass here, but what has happened is that because the 2D echo is a slice technique, it's cutting the top of that lobe here, and once cutting the top of the lobe here, it's looking at the lobe en face, so it gives the impression of a clot, while it's actually nothing but lobe. So obviously now there was no problem here. We successfully went and he was sent for ablation, which was very successful. Also remember, the other things can cause what may look like a clot. For example, here a patient with tuberculosis and who also had atrial fibrillation. Look at this; it looks like a big clot in the left atrium here, right there. And that's what we thought in the beginning. Then we did a 3D echo on this patient. And with a 3D echo, you can see this caseation here. Very important, interesting caseation, just like pathology. You can see this fibrosis here and lots of areas of caseation. So this made us think that this is not really clot, but something. It's not really those nice little echolucences, holes in the clot, but they are surrounded by these thick bands. So this is not like a echolucency. So actually this gives us an idea that this may be something else, and the patient was having tuberculosis also. So then we knew that this is probably caseation, and was proven at, later on it was proven. So how do you differentiate these holes in the, if you see something like a hole in a mass, how do you differentiate? So clot will of course have a hole in it right in the middle, which will expand to go into the periphery. And of course, these are always associated with low flow state, low ejection fraction of the left atrium or left ventricle. If you look at a myxoma, you'll also have holes because of hemorrhages, but many times myxoma is slow growing, so you have areas of calcification. And then you have these tuberculomas and other malignant cells. These will have bands of echo around it, look like a donut, band of very bright echoes. And of course, hemangioma will have holes all over. So this is the way you can actually distinguish many pathologies using three-dimensional transthoracic echocardiography. Remember, should always remember the right atrium also. For example, here is a patient where you have actually clot in the right atrium, but also clots in the left atrium. So what has happened here, of course, the clot has gone. It's a saddle-shaped thrombus. Clot has gone from the right atrium into the left atrium. And so these are very important things by three-dimensional echocardiography, clot going through the PFO from the right atrium into the left atrium. Now let us look at something about just a few minutes on how we can sometimes close the left atrial appendage by using various devices like the Watchman device or the Amplazer device. For example, here is the left atrial orifice here, left atrium, and what one can do here in some of these patients here, if I can play it again, one can take a section across by 3D echo on the top here, and if you do that, you can actually see the appendage here. In unfast view in short axis, the appendage right here, and so you know exactly the dimensions of the appendage, you know the circumference, area of the device, you know exactly what size of device to put in to close that appendage here. So here is the view, unfast view of the entrance of the appendage. And one can actually look in 3D echo also. You can see this is the LA orifice here. Those are some of the pectoral muscles. And these are true view. This is another technique in 3D echo where you can see these appendages very, very clearly here. It's like taking a torch and shining on the 3D echo. And so here is one patient example here to show here is the left atrial appendage. So this was measured here. Could get the circumference of the entrance to the appendage. And then you can look at it again in three-dimensional echocardiography here. You can look at it and then you know exactly what type of, what size of the device to put in. And here we have put in the Watchman device here to close the appendage here using 2D and 3D echocardiography here. So when you put in the device, you have to be very careful. There should be no flow coming out of it. If the flow comes out of it, that means the left atrium is not, appendage is not fully closed. And if it's not fully closed, that is even more higher chances of getting a clot formation. So why this happens? Well, even if you sometimes do a 3D echo, you close it, there's still some. The reason is that when these patients are many times have been fasting, so they are dehydrated. So what you do is, before you actually try to even size the orifice of the appendage, give them fluids first. Give them fluids so that the atrial appendage expands, and then you look at the size, and then you put the device. So here is how you put the device, and what you look for is device position, and you can see device migration, just like you saw clot migration. Look for pericardial effusion if you perforated the appendage, and then you look at peri-device leaks, but hydrate the patient, very important. Hydrate the patient before checking. So you must hydrate the patient and then and then that way you minimize the leaks. And very small leaks, 3 millimeters or 5 millimeters or less, may not be that important. Check for any thrombus associated with the device. And of course, when you put the device in, you tug it a little bit to make sure it won't migrate, but don't tug it too much, but tug it a little bit, and then you let it go. And then of course, you also look for any intra-atrial shunt because you are actually perforating the atrial septum to put the device in. And this is to show you the surgical specimen of the device, and then look at how the 3D on the three-dimensional transesophageal echocardiography, you can see the device very, very clearly, as good as you can see the surgical specimen. So 3D echo becomes very, very useful here. This is a lariat device where you actually what you do is you put in a suture through the between intraparticle space and then close the appendage here. So here is the appendage, and then if you look at the part of the device, suture is here, and then here the appendage is completely closed. So this is another thing one can do. Now what happens if you have a clot and the clot is not dissolving at all? What do you do? Well, more recently people have been again putting the device even though there is a clot present. So what one does, very important to do a 3D echo of course here. So you look at the size of the, of course the clot should not be prolapsing out so long as the clot within the appendage. You can put a device in, and this is taken from a recent paper, came out in one of the journals here. And So here is, you can put the device very clearly here. So you can still put in a device in a patient with left atrial appendage with a clot in it. If the clot hasn't dissolved at all and you're really stuck, it's not that easy, and you could still disrupt the clot. And you can put an emplacer device very carefully using 3D guidance. And when you do a 3D guidance, you make sure you don't go too much inside the appendage and then close it from the top, and that actually works very well. Now, of course, a patient like this who has a clot in the appendage as well as a clot outside the appendage, you cannot do that, but if the clot is within the appendage completely, you can close the device. I think this is a very brief assessment of the echo, and there are many things to go for here, but I give you a little bit of a bird's eye view of the usefulness of echo in atrial fibrillation. Thank you very much for your kind attention. Hello? You all heard me?
Thank you very much, Naveen. I think it was a very nice presentation. The echo evaluation is a real cornerstone in any patient of atrial fibrillation. It has got diagnostic, prognostic, and therapeutic implications. Naveen has shown very beautiful slides. I think those slides were such an important that it can be used echo guided for putting in the various devices, like you mentioned about the Watchman device, an emplacer device, as well as we can see the validation of the effect of NOAC. So my topic in continuation is NOAC and echo navigation in atrial fibrillation in India and the real world. I think Naveen has shown a very interesting case, tuberculosis versus clot, which was very nice, where he has shown how the causation was seen by echo, and we could make out that this patient had tuberculosis and not a thrombus. So my topic is NOAC and echo navigation in atrial fibrillation in India and the real world. How to choose NOAC, whom to be given, and when to be given, and how to be given. The good news is NOAC in atrial fibrillation has come to stay. There is a clear-cut exodus of VKA, safe, effective, and promising, better compliance and adherence, and is very useful for the stroke prevention as well as for the stroke treatment. It is also used for the treatment and prevention of DVT, VTE, and we can see non-valvular atrial fibrillation and valvular atrial fibrillation, and bioprosthetic valves are also the indication for NOAC these days. No monitoring is required, no PT and INR, quick onset of action and quick offset of action, first line management, low bleeding risk, very cost effective, and there is a huge data to support the morbidity and the mortality benefit, and antidotes are available for all the NOACs and is useful, as I mentioned, in VTE and ATE. What's the bad news? The bad news is certain NOAC cannot be used when the eGFR is less than 15. If it is less than 15, we have to use warfarin. If it is 15 to 30, we can use rivaroxaban. If there is hepatic insufficiency and there is a black box warning or metallic valve, especially for NOAC, where only VKA has to be used. NOAC has not to be used in pregnancy, lactating mother, malignancy, and antiphospholipid syndrome. Recently, I just got a paper this morning which has mentioned the usefulness of rivaroxaban in a small dosage in a very, very nice study, and in combination with aspirin, the morbidity, event rate, and mortality is very low after PCI or in the chronic coronary artery disease, which we shall be discussing very shortly. This is just to show the history of the anticoagulant therapy. It is more than 110 years, 80 years for Coumadin, and almost 40 years for warfarin, and about 11 years for NOAC. This is how I think the best work has been done by Canadian author, and the name of the Canadian author is Stuart Kennerly from Canada, who did a real registry work in the RELY registry in 2009 to show the validation and the importance of NOAC, especially with dabigatran. AF burden, as I mentioned to you, is very, very high. Echo navigation, you heard very beautiful and a very lucid presentation by Naveen. And NOAC navigation is very safe, efficacy, and outcome evaluation can be done by echocardiogram. And choice of AF with ATE, DVT, and VTE is really important. So, ladies and gentlemen, echo is very important to diagnose, to prognosticate, and therapeutic implication. So, the role of various VAS score and CHAT square is limited. But echo is very, very important. Without echo, we can't see the efficacy, safety, or the outcome of NOAC. The global data is very well known. It's 2% at 40, 4% at 50, 6% at 80, 8% at 70, and 10% at 80. As the age advances, the prevalence becomes more. And see, 14 crore people are suffering from atrial fibrillation worldwide. And if you see here, 20% of strokes are cardioembolic, out of which 90% of non-valvular atrial fibrillation has a left atrial appendage clot. This is just to show the data and the burden, more common in males as compared to females, and the mortality is more common in females as compared to males. See, in the Southeast Asia, the burden is rising more in Japan, Korea, China, and then comes in India. In 2014, the burden is going to be very high. How do you identify? As I mentioned to you, by CHAD score and CHAD-West score. But I personally feel, practically, what I see, echo is a real cornerstone to see the stroke and DVT and VTE. Naveen has mentioned about even the foramen ovale. He also mentioned about the carotid plaque and atherosclerotic plaque in the aorta. And atrial fibrillation may mobilize and may cause a thromboembolic episode, which can see only by echo. There is no other way. It is a economic burden. $26 billion are utilized only to manage the morbidity created by atrial fibrillation. Now, what is the importance when we do echo? We find the cause of atrial fibrillation, as mentioned by Naveen, to cardiovert or not to cardiovert in presence of a clot, or in presence of a LA strain. As he mentioned, if the LA strain is less than 12, minus 12, then or it is more than minus 12, it is very, very important to predict the recurrence. He mentioned a very important point. And then any LA or LA appendage clot, will sinus rhythm will persist or there will be recurrence? We can easily predict by echo. The echo is the only way where we can predict the recurrence after radiofrequency ablation. Then warfarin or NOAC, what to use depending on the metallic valve or no metallic valve, and what is the stroke risk, all can be predicted by echo. I won't go to the details because Naveen has already spoken. We use all conventional Doppler, tissue Doppler, 3D echo, and spectral tracking, strain rate, and LA stiffness, or even the torsion. This is what has been expressed by him very beautifully. And the more concentration on LA size, LA diameter, and LA strain, and LA ejection fraction. And even he mentioned about the atrialization of the mitral annulus, which is very, very important. And we can see the LA, we see the stasis there, or we see the sludge formation, or the LA appendage, or the low flow velocity of the LA appendage. And hemodynamics, he mentioned about the E prime ratio. We can see here, there are 4 categories of patient here, a rheumatic heart disease. In mitral stenosis with atrial fibrillation, we can give NOAC. But when there is a moderate mitral stenosis or severe mitral stenosis, we don't give NOAC. Acute mitral regurgitation with MR, NOAC can be given. Any patient who has got a lower atrial fibrillation, as it is seen here, we can see a beautiful LA appendage. Or if a person got a restrictive cardiomyopathy with an RA enlargement, so we can also evaluate RA and RV to their details. And we can see here the LA appendage clot, which is very important. If it is less than 3 days duration, we can see in 14% of patients with atrial fibrillation. If it is more than 3 days duration, we can see 28% of atrial fibrillation. This is just to show how we can see the LA appendage, which can be scanned through all the angles very beautifully. And we can see all the 3 components of the LA appendage. The base of it, or the neck of it, the body of it, and the apex of it can be beautifully seen during the, and we can also see the flow profile in the LA. We see here very nicely the LA appendage, and we can easily distinguish whether there is a clot or there is no clot. We can see here, as Naveen was pointing out, a sludge or a smoky appearance, a very, very characteristic feature. A lot of patients may get a thromboembolic episodes without any clot in the LA appendage, but they may have a smoky appearance. They are all the candidates who should be given NOAC. And you see here, this was the data, this was the study published by Ravi Kasliwal, our own colleague, and we can see in the LA appendage a smoky appearance, so beautifully seen in a patient of a rheumatic heart disease, what we call a spontaneous echo contrast. And then we see here, in the 3D echo is definitely superior because more accurate, unlimited planes, comprehensive of the LA clot as shown by Naveen. We can also see the calcification. A very nice point expressed by Naveen is, we can see the cavitation which starts when you give an anticoagulation from the center, as compared to a clot lysis which happens from the periphery. So we can see the lysis, we can see the mobility, and also he has shown the volume of the clot can be very well assessed by 3D echo. LA volume, as he mentioned very clearly, is a very, very important. We call it as a glycosylated hemoglobin of left atrial fibrillation or heart failure if it is more than 34 ml per meter square. LA volume is very, very important variable besides LA diameter, LA stiffness index, as well as LA strain, left appendage velocity, and LA stiffness index are the important variables. As Naveen has mentioned, incremental value for LA function evaluation, every patient should be evaluated for a LA strain. And he mentioned the three components of LA strain, the cavitary, the contraction, and the conduit. The more important is the contraction which we see here. We divide it into 6 segments and do an apical 4-chamber view and 2-chamber view. And you see here, the LA strain is less than -12. This patient got a stiff LA and less deformity. And see the data published in the Journal of American Society of Echocardiography as showing when the global LA strain is less than 12, the survival rate is low. And when the global LA strain is more than 12, the survival rate is high. To conclude, this is a very important point of the data of LA strain, which shows that we can see the fibrotic atrial cardiomyopathy, atrial dysfunction, persistent atrial fibrillation, paroxysmal atrial fibrillation, recurrence can be predicted after CABG, after the anticoagulants, thromboembolism, everything can be seen. We can see even the LA remodeling or the reverse of the LA remodeling can be predicted by echo. See the global LV strain. I think because of positive type Naveen is not mentioned, whether it's a global longitudinal strain or radial or circumferential strain which are affected the ventricle may also be responsible for atrial fibrillation. Even we see number of times the torsion. The torsion is usually not seen in a heart failure with preserved ejection fraction, but when there is a reduced ejection fraction, we have circumferential fibers involved as well as LV torsion is reduced. LA stiffness index is a new variable which we use very commonly these days because this is a ratio of E by prime ratio upon LA strain rate. If it is more than 1.1, we are more prone to have atrial fibrillation and atrial clots. This is a textbook which was I think 4 years ago, which was published by our group. And this is just to see the oral anticoagulants, which can be VK like warfarin or acetylcholinesterase, and factor Xa antagonists like rivaroxaban or edoxaban or apixaban, and direct thrombin inhibitor in dabigatran. And see the comparison. We see here the 2A antagonist is dabigatran, while the 10 antagonists are apixaban, edoxaban, and rivaroxaban. The bioavailability is highest with the apixaban, and we see the half-life is almost equal, 12 to 15 hours. And we see here the dose requirements is BD dose, 110 milligrams or 150 milligrams BD in dabigatran. Apixaban is 2.5 or 5 milligram BD. Edoxaban is not available here. And then we use rivaroxaban as an OD dose. But now the COMPASS study, which was published and shown, I just mentioned to you, where they given 2.5 milligram BD in the patient of chronic CAD, like in acute coronary syndrome, they are given chronic coronary syndrome, and they found a very, very important data, follow-up patient for almost 3 years. So there is a huge data post-PCI and chronic CAD to give this drug rivaroxaban along with aspirin, 75 milligram, and the morbidity, event rate, and the mortality is significantly reduced. Antidotes are available with all the 3 antibiotics. I won't go into the details of mechanism. This is the outcome data. The outcome can be evaluated by echo. And we see here the trials. Meta-analysis of 71,000 patients have shown very clearly they favors NOAC as compared to VKA. RELY data by dabigatran, ROCKET by AF, rivaroxaban, and Aristotle by apixaban on ENGAGE trial by endoxaban. It is shown very clearly the safest drugs here are dabigatran and apixaban. Bleeding is less. We see here the major bleeding complications are less with apixaban and dabigatran as compared to rivaroxaban, where the GI bleed was shown to be more. So this is very important guidelines. NOAC agent is of first choice in NVAF with Z square and V square of more than 2. TTE and TEE are sensitive and specific for NOAC effect and outcome evaluation. And echo is a must. This data was published by our next textbook on imaging when Naveen Siddhanta was also the chief editor with me in 2018. This is just to show that NOAC are recommended in every patient having atrial fibrillation or of choice, whether we use dabigatran or apixaban. And there is a black box warning, as I mentioned to you, the metallic valve, it is not to be used. See the mortality data. All-cause mortality data of dabigatran is less as compared to apixaban. You see here, dabigatran and apixaban are very, very important agent in the NOAC. See here, the real-world data of safety and efficacy. The dabigatran and apixaban are safer as compared to warfarin or rivaroxaban as far as the data we have. So, ladies and gentlemen, matching of NOAC can be done when a patient has got a recurrence rate, and if he's got a renal insufficiency, rivaroxaban is the agent of choice. And if there's a bleeding anywhere, then the more preference is given to dabigatran. And the same thing has been expressed here. We can see here the data, and this is just to show that moderate to severe mitral stenosis or mechanical heart valves with atrial fibrillation, no NOAC has to be used. There is no this thing. And these are all the studies where we found NOAC is superior to VKA and DVT and VTE in the RECOVER study or Einstein PE, Amplify or HOCUS-I or ReMedi or ReSonate data shown very clearly that NOAC are superior. And see the data. The real world data on morbidity and mortality is very clear that it is superior with dabigatran and apixaban and to some extent with rivaroxaban, but not with edoxaban. We can see here all-cause death rate is significantly reduced with dabigatran and apixaban, and the bleeding tendencies are less with apixaban and dabigatran as compared to rivaroxaban. To conclude, ladies and gentlemen, atrial fibrillation is a major public health problem. The prevalence is quite high. We know in India, we see a lot of patients coming to us with a stroke or TIA, with the underlying rheumatic and non-rheumatic NVAF, having a hypertension, diabetes and CAD, post-PCI or post-CABG, and the NOAC are very sensitive and specific. Echo, we can evaluate in detail, we optimize the line of treatment. LA strain, also mentioned by Naveen, is very, very important. Every patient to whom we analyze, please give the information about the LA strain so that the electrophysiologist can easily decide which patient should undergo radiofrequency ablation, or he can prognosticate and explain the relation, the chances of recurrence, or a catheter ablation can be easily explained to everyone. NOAC is the most promising and powerful agent. I personally believe that the future is of NOAC with the antiplatelet drug. We use DAPT, dual platelet, antiplatelet drugs, but the mortality and morbidity and the event rate is still high. So time has come that we have to give a dual pathway, antiplatelet and anticoagulant combined in the low dose. And that is going to be the future. And I think the data was recently published and has shown in two studies. One is a COMPASS study and second is the Voyager PAD study where they use a peripheral vascular disease. 1/3 of this patient underwent a surgical treatment and 2/3 of interventional treatment, and they were put on combination of aspirin as well as rivaroxaban 2.5 mg BD, and the outcome was very good. So NOAC has really come to stay with the superiority of a single platelet agent alone. But NOAC has a tremendous morbidity and mortality benefit both in ATE, DVT and VTE. Dabigatran and apixaban are the agent of first choice. Rivaroxaban, I am not condemning it, but it is also an agent of choice with the new data like COMPASS study and Voyager PAD study, which was just released only yesterday or day before, and they are very, very useful. And we have to decide our patient. CHAT square is positive in more than 2 in almost 90% of patients. Ladies and gentlemen, echo evaluation is a must. So what's the take-home message? Health of millions is at stake with atrial fibrillation in India. And various modalities of echo are very, very useful. Whether it's a 2D or 2D TE or 3D TTE or 3D TE, all are of a great application clinically. Various echo variables mentioned to you, we should investigate all these patients in detail. Timely NOAC intervention is the need of the hour to prevent the morbidity and mortality, especially in stroke VTE. Time to act is now to create our own echo AF protocols with NOAC, whether we use dabigatran or whether we use apixaban or rivaroxaban. They are very, very important. And I think all the agents are very important because rivaroxaban initially was used as single dose, 15 milligram or 20 milligram OD in the VTE, but now in the CCA, chronic coronary syndromes, they are using a small dose, mini dose with aspirin, and the data is very good. They are also using sub-studies with clopidogrel. We must act locally and impact globally. This is a very important slide. I love it. This is a message conveying slide that here is a lion and here is a tiger. You like lion or tiger, choice is yours. The lion is dabigatran and apixaban, while the tiger is rivaroxaban and rivaroxaban. Thank you very much for your kind attention. So, ladies and gentlemen, the third topic is also of a great relevance now. We already seen the evaluation of atrial fibrillation and the application of NOAC in clinical practice. NOAC has come to stay, as I mentioned to you, and there is a huge data to support the usefulness of NOAC as NOAC alone or along with the antiplatelet drugs like aspirin or clopidogrel or other antiplatelet drugs. And now we have Professor Dr. Shiri Shiramat, who will be giving us a very important data on comprehensive CAD prevention strategies. Dr. Shiri Shiramat, sir.
So good evening everybody. You heard two outstanding presentations. I'm in Pune and we'll be talking about coronary artery disease prevention. So this is the early 80s when this boy presented with severe hypertension, bilateral renal artery stenosis, a diseased aorta, and he had severe hypercholesteremia. So between year 8 and year 13 he died, because in those days, A, we never sort of gave so much importance to cholesterol, and B, we had very few in our armamentarium to treat these kind of very high cholesterol levels. This is mid-90s, and you can see this gentleman at 29 he had 1 MI. At 42 he had repeat sort of angina from this lesion, which was treated with angioplasty. And at age 49, he again came back with a critical narrowing at the distality of the left main. So coronary artery disease, we can clearly understand, has a progression. And I'm going to touch upon a little bit on lipids and how we can get better at it. So the earlier studies, the first study on lipids in early 90s, the 4S study showed that high LDL you can bring down and you will see the benefit. As time has passed, we are now talking of normal LDL should be brought down and you can still see the benefits. So we have all understood the importance of bringing down cholesterol. So this is TNT study, 10,000 odd, 6 years follow-up, and you can see 10 milligram and 80 milligram dosages of atorvastatin. And the 80 milligram brings it down and over 6 years continues to maintain at a lower level to give you a major benefit in cardiovascular events compared to 10 milligram dose. So we are now talking of high intensity or moderate intensity statin. Similarly, the Improve It study, which used ezetimibe to bring down the LDL levels. You can see here the ezetimibe group, and these were consistently held down for next many years with a combination of atorvastatin and ezetimibe. So ezetimibe, which was a little bit out of style, has come back into management of LDL values. And we can see from this 4 different lipid lowering trials, the number need to treat with a high dose statin is much, much smaller compared to anything. So don't shy from using a good dose of statin when you are trying to get the LDL down. So the Lipid Association of India, in very high risk individuals like previous ASCVD, diabetes with organ damage, etc., they have already indicated that LDL value should be less than 50. And both the ACC, AHA, they are also looking at this figure of 50 or 55 very strongly. So we will all probably think of treating these high risk or very high risk with figures of less than 50 for, or 50 or 55 for LDL. The clear change in thinking in the ESC can be seen in 2016 guidelines to 2019 guidelines. And here, the high risk, the LDL values was 55 compared to 73 years earlier. Also, the duration of exposure to high level of lipid also becomes very important. This is a meta-analysis which explains to you that the earlier you start the LDL therapy, better it is because you are reducing the duration of exposure. So at 30, 35, when somebody comes to you with a very high LDL, very important to repeat his LDL with lifestyle modification, etc. But if he is not at target, I think it's very important to give him medication so that you start over a long length of years, you bring his LDL values less. So somebody who has low threshold at CHD, you bring it down. Instead of presenting at an early age, he would present at a much later age. So this is the meaning of starting early. The same was seen with evolocumab also, that those who were started early following MI, less than 2 years, I think the number needed to treat was much less compared to those who got it later. So this is again evolocumab, the EVOPAC study where it was used early after an ACS compared to 4-year data. And you can see a bigger benefit in those patients whom it was used at an early stage after acute event. This is again a Thai study where high proportion of ACS patients prescribed high intensity statin. In 2013 only 10% was prescribed, and in 2017 almost 88% of these Thai patients received statin. So there is a clear shift in our belief that as we move from 2010 to 2020, the high intensity statin is probably the way to go. The ESC also had a similar feeling that between 2016 and 2019, if you can see here, the event rates were much less with new guidelines in 2019, where 55 or 50 was the target LDL compared to 2016, where it was 77. So this is how it is, 2019 versus 2016, and increased statin eligibility. More patients were included because the targets were lowered, and you can see the benefit compared to 2016 and 2019. More prevention, more events were prevented in this group compared to 2016 targets. So overall, a very high risk familial hypercholesterolemia patients, a combination of PCSK9 with statin is strongly recommended, class 1C indication. This was the data from the 4-year study. Evolocumab showed drop in the Lp(a) values. Now, Lp(a) is something which is not very clearly understood, but it appears that the evolocumab is the only drug which is bringing it down. The inclisiran, which is the first gene silencing medication, NHS is doing a pioneering work, and it has shown that it's every 6 monthly injection. So first injection would be a little bit early, after second one after the first one. But then every 6 months, and you can see a persistent drop in the LDL around 50. Fortunately for us, the statins are reasonably safe. So using high-intensity statin therapy effectively reduced LDL and is safe. This was a study from Taiwan which showed that there is not much difference between high-intensity statin and non-high-intensity statin. So you can use high-intensity statin pretty safe. We switch from statins, which are strongly recommended for prevention, to antiplatelet agents. And you can see here, following ACS, DAP therapy is strongly recommended, especially with ticagrelor. There has been a benefit amongst all the subset, those who had STEMI, those who had non-STEMI, and those who were managed with medical management, and those who were managed with PCI. So amongst all subsets, you see all these are ticked. That means DAP therapy to extent of 12 months is strongly required. Going beyond, we have two important studies which included high-risk individuals, those who are more than 65, those who are diabetics, those who have multivessel CAD and chronic renal failure. The Pegasus and the DAPT study both sort of highlighted that if you go beyond 12 months, there is a benefit compared to placebo. So this is actually 60 and 90 milligrams of ticagrelor in Pegasus compared with placebo. So in high-risk individuals, there appears a strong justification that we should go beyond 12 months. 12 months, of course, but beyond 12 months in high-risk individuals with low possibility of bleeding. So those who are at high risk of bleeding, you would probably try and keep this shorter, but those who have low possibility of bleeding and high risk for ischemia, I think you need to go longer in duration. Aspirin has come under a lot of weather. This was actually a Plato analysis, and it shows that low-dose aspirin as well as high-dose aspirin, these did not make too much difference. And if less is more, will none be even better? That's the question we should ask. Aspirin again got a big hit when Twilight study was presented recently, and it showed that if you stop aspirin at the end of 3 months, so this is actually a ticagrelor monotherapy arm, and this is a ticagrelor aspirin arm, and you can see the ischemic benefit is same with both. And most of the difference comes because of a higher bleeding episode when aspirin was combined with ticagrelor. So we start believing, even TICOP study from the Korea gave similar kind of inference that beyond a point, you don't need aspirin for a longer duration. When we talk of atrial fibrillation and diabetes and a PCI, we need two important components. We are dealing with two important components. One is because there is a PCI, dual antiplatelet therapy is strongly required, and because there is a FAB, you need oral anticoagulation to prevent embolic episode. The Pioneer AF data clearly indicated that rivaroxaban was much superior to warfarin group of medication. You can see the bleeding episodes were much less with 2 dosage of rivaroxaban, 15 and 2.5 twice compared to warfarin group. So it appears, and you heard already, even in redual PCI, the dabigatran 2 dosages compared to warfarin clearly safer than the usage of warfarin. So NOACs overall are class 1A indications amongst the anticoagulants for many issues. When we have this combination of atrial fibrillation and a PCI, and if you have low risk of bleeding, you try and give these three, the anticoagulation plus the DAP for about 6 months. Then you have anticoagulation and one of the antiplatelets. And beyond 1 year, you put them only on anticoagulation. Which one, I think time will tell, but at the moment it looks like the NOACs could be a strong possibility. If your patient has HBR, that is the high bleeding risk, this initial triple therapy is kept only at 1 month, and then you switch to dual therapy with oral anticoagulation. When we talk of reduction in diabetics, we have these SGLT2 inhibitors. There is a comparison of these three, and you can see that they have a benefit for heart failure hospitalization, 3-point MACE, CV deaths, and good renal outcomes too. So it appears that diabetics who are most likely to have a intermediate or high risk should be on these SGLT2 inhibitors. So you have to remember that once there is an MI, there is a stronger possibility. This is actually a Swedish study, Apollo Helicon, where ACS has happened, and when you follow 1 in 5, that is 20%, will come back with this episode. So this is where the importance of our prevention, the secondary prevention, is going to be very, very important. The second event happens very early after the first event, and that's why all the aggressive therapy should be started as early as possible in hospital. The second event generally happens from non-culprit lesions compared to the first event, which has happened from the culprit lesions. And this is what we are trying to prevent. And if you see the earlier studies, they were mostly for secondary prevention, starting late. But then as time has gone, we realized the importance of statins. And then when we got it into secondary prevention and then into primary prevention. So at this stage we are talking of a chronic phase which should be stabilized, and these patients should not be allowed to go back to an acute phase. And this is the OCT images which has shown that once you put a patient on high intensity statin therapy, the plaque stabilizes from within, becomes from a thin calf fibrous cover to a thicker calf fibrous cover, and this will avoid repeat episodes for this patient. So this chronic coronary syndrome, we should try and keep the patient stable. However, repeat events are a rule, and this happens because of thrombus resisting factors. So stable angina is a myth. You will always get an events coming up. So do we have anything beyond aspirin and DAPT? And do we have anything in the antithrombotic regime? So the chronic coronary syndrome, CCS, encompasses a sizable clinical spectrum of coronary artery disease, and this is what we are talking about, antithrombotic therapy. Do we go beyond the DAPT? And this is where the importance of COMPASS eligibility. You have the CAD patients, multiple risk factors, and you have PAD patients. So both these stable patients, they strongly benefit with rivaroxaban given as 2.5 milligram twice with aspirin. You see the benefit is similar as rivaroxaban 5 milligram, but the bleeding incidences were much less, and plain aspirin did not give the benefit like these two components. So rivaroxaban with aspirin is probably the way to go. So this is called as a dual pathway inhibition, aspirin and rivaroxaban, and you would probably reduce the MACE rate very much. And this starts very early. Again, we have been talking of starting as early as possible so that patient gets the benefit. The maximum benefit was seen in PAD, and the bleeding risk compared to antiplatelets in Pegasus is much less with this combination of rivaroxaban 2.5 twice with aspirin. So the COMPASS data for chronic PAD population is very strong, like reduction in the amputation rates was very high, almost 70% reduction. So I think the way things would change for prevention of coronary artery disease, we spoke about aggressive statin therapy. We spoke about antiplatelets given for longer length, and now we are talking of adding the NOACs to this. And these, for dual pathway inhibition, these are the enrichment criteria of elderly patients, smoking, diabetes, renal dysfunction, heart failure, carotid disease, peripheral artery disease, and prior stroke. So if you have these, I think these would benefit with this combination. So we had this COURAGE data in 2006 where medical treatment was close to the angioplasty. However, the COURAGE was heavily criticized because the test usage was small, it was felt that it was not the best study and so on. However, 14 years later we have the ischemia study, and this actually had everything that you would expect from the current revascularization strategy. But even in ischemia, there wasn't much difference between the conservative therapy and the invasive therapy. Now, to achieve this kind of conservative results, we need to drop back to UKPDS, which was actually had this metabolic memory. So those who were very aggressively controlled in the early years, in these years, they actually benefited over a long length of next 20 years. The control may or may not be so strong as during the trial. Now, this metabolic memory is true for hypertension, as was seen by ASCOT BPL follow-ups, and it's also true for statins. So if you start early, the diabetic therapy, the statin therapy, and the antiplatelet therapy, you are probably going to do a benefit. I would end with a small case. This was at age 50 when he was already diabetic for 17 years, a small lesion in the right coronary artery. 1 year later, progression of disease for which an angioplasty was required. A few years later, I mean, there were some follow-ups which were not too bad, but 2003, that is about 5 years later, he had aggressive disease for which he needed a bypass surgery. And after another 8 years of the bypass surgery, 2 of the limbs from here to here and from here to here, they were blocked. So we had to do an angioplasty to set him right. So if you have a patient who is high risk in front of you, you probably need to think of all these and probably do evaluation with a calcium score, a CT angio, and while we are actually looking for CT coronary angio with a non-invasive IFR, FFR to tell you whether the blockage seen on CT coronary is giving ischemia. So with all this, I think we would probably expect a very good result. No talk today can end without COVID, but I would skip some of these slides. Though it is always argued, can it cause CV disease? Yes, it can cause myocardial injury. It can sort of erode the plaques, and it can give an ST elevation, though many people say it's a false ST elevation MI. Chronic coronary syndromes, those who are in chronic coronary syndromes, and now we are going through this phase. I think the medication should be continued to offer them a strong safety. The blood thinners are of course going to be very important, for these patients with chronic coronary syndrome. So don't ignore even if they are not able to reach you. Thank you indeed for your attention, and I enjoyed participating in these interactions.
Dr. Shirish Ramat, I think I just like to give very important messages of this session before we open for discussion and questions and answer. The first important, when Naveen spoke, he gave a beautiful evaluation of echocardiography in patient of atrial fibrillation. It's a real problem. We all know it. Every patient of atrial fibrillation should not be taken easy. Whatever method you adopt, whether it's an EKG or a Holter or a loop recorder, you must establish the diagnosis of atrial fibrillation, and of course we use those scores, and after the scores, echo validation is must, and a serial echo follow-ups are must. And he's shown us beautiful, the clots can be in the LA appendage, RA, MV, or even in the foramen ovale, and even SVC and IVC should be investigated in details. A very important message. Word about NOAC, and I think to a very large extent, I'm very happy that Shirish also spoke the same thing, because it is very important. A time has come. We need to have paradigm shift. People who are on antiplatelet drugs should not be confined to antiplatelets only. We should move in this patient of atrial fibrillation to NOAC. They are very safe. No monitoring is required. Cost effective. It can be easily seen even as outdoor. No INR, no PT, and it's very, very important. I think Shirish has also mentioned that we use rivaroxaban, and the data is in favor of all the three: pixaban, or dabigatran, or rivaroxaban. So far as Shirish is concerned, he gave a wonderful talk, and he started with a high dose of statins, what he calls a high intensity statins, and his focus was India is the world capital of diabetes and coronary artery disease and metabolic syndrome and STEMI and atrial fibrillation and heart failure. We must focus on a high dose. We should not be scared. No side effects. Whether you use a torvastatin or rosuvastatin, we mentioned our target should be 55 milligrams of LDL, which is a very important point. A very important point suggested by Shirish. He also mentioned PSK19 can be also used in the patients who have got a hereditary hypercholesterolemia, homozygous or heterozygous. And third important point he mentioned about the antiplatelets. The first year after PCI, they use the word, very important, tecogerelol is of choice, with aspirin, without aspirin. And I think he mentioned very categorically that a time has come we should introspect. All these patients, which is shown in the last slides, may initially have a single vessel disease, may have a double vessel, triple vessel, carotid, aorta, peripheral vessels, and intercerebral disease. To halt the rising menace of vascular disease in the whole vascular tree and create a vascular health, we must give them long-term single antiplatelet drug and one NOAC. The choice is yours, whether you want to use rivaroxaban, low dose, not high dose, so there's no bleeding, low dose 2.5 milligram BD, as he has mentioned very rightly in data from COMPASS study, as well as in the peripheral artery disease by Vogar PAD study, which is very clearly for 3 years data, have shown the benefits in the form of outcome, both mortality and morbidity. His point is very well taken, that ACS and CCS should not be taken so easy, and CACS should not be ignored. He used the word, Dr. Shirish, that it is every patient who becomes the victim ultimately of CCS. We can't keep on doing angioplasties or bypass surgeries repeatedly in all the patients because they need an effective medicalization. He also shown the current study and the Ischemia study. He is an interventional cardiologist, but he talks a lot about the prevention. He talks of primary prevention, secondary prevention, and tertiary prevention. And I think he has given a complete view. High dose statin, aspirin, along with NOAC is the future if you really want to prevent the rising morbidity and mortality, which is CCS induced ultimately. I'm very grateful to you, Shirish MSc Ramat sir, and Dr. Naveen Senanda for your beautiful words of wisdom. I'm sure it will create a huge impact. There are some questions. The first question is from Mumbai. Suresh Mehtalia, he mentioned in the question, what would you recommend for diastolic dysfunction, atrial fibrillation, flutter, and pulmonary hypertension? Naveen, you want to answer or should I go ahead?
You can go ahead. It's okay. It's okay.
I think the answer is very clear. Any patient who is a diastolic heart failure or a systolic heart failure, as we mentioned, every patient we should see the E by prime ratio, the LA volume index, and we also measure the LA stiffness index. And if a patient got atrial fibrillation, we should see that these patients can undergo radiofrequency ablation or not. As we mentioned, the LA strain cutoff point should be known to all of us. And we should give the patient treatment, medical treatment, diuretics, beta blockers, everything should be given. Regarding the intervention, I think all the variables which we just mentioned should be thoroughly evaluated. The second question is by Praveen Gupta, New Delhi. And he mentions that there is a lady, Shinam, from Chandigarh, 28-year-old female with a history of orthostatic hypotension since 8 years and a history of syncope following exercise with normal echo, Holter, and other studies. How to proceed next? Dirish, 28-year-old female.
I understand. This is something which is difficult to treat. We must strongly rule out diabetes. You may have do an extended GTT, check the family history and so on. In general, to prevent syncope and fall, you should tell her to have adequate hydration, especially in the later part of the evening, so she doesn't drop pressure when she gets up. We should obviously stay away from medication as much as possible. So that's why this is a simple precaution. If she is not hypertensive, maybe she can be a little bit liberal on salt intake, which will again sort of retain fluid in the body. And there are some medications available, especially forget the name, metadone, or the dosage is between 2.5 to 10 milligram. It should be given in the evening times, and then the second dose can be given in the morning. So these can avoid orthostatic hypotension. But in general, stay away from medications, because how long are you going to give these? Do evaluate, but I think you can stay safe from medication.
I think it's a very important point which Dr. Shirish mentioned, that all these patients should be investigated for sympathetic dysautonomia, and as they have, and as you mentioned, that there should be diabetes or no diabetes. As you mentioned, that there is orthostatic hypotension, they should be thoroughly investigated. And I totally agree with Dr. Hiramat. You have to be as away from medicines as possible, so that no accentuation of postural hypotension to take place. And very important precaution is told, such patient should not be dehydrated. Next question is by Praveen Gupta, New Delhi. What is the role of his bundle pacing or LBB pacing in heart failure? I think it's not relevant to this. Do you want to respond, Hiramat?
No, I'm away from these things.
I think we just forget about this. Second question is by another question which is there. What is the key message from largest RVE study, Aristophane of Novak in NVAF, Dr. A.K. Pancholia? I think the answer is very clear. The data is very clear, Dr. Pancholia. Whether we use Rivaroxaban or Apixaban or we use Dabigatran, and the message is that every patient who is given this treatment should have a thorough evaluation periodically by echo. And there is a huge data worldwide to show the power and promise of these three anticoagulants, especially in atrial fibrillation, non-valvular atrial fibrillation with Apixaban as well as with Dabigatran. And now with CCA, we see a lot of patients, ACS and CCS, we see a lot of patients where we are giving Rivaroxaban. And I think very nicely expressed by Dr. Hiramat, the COMPASS data as well as the peripheral vascular data. In the future is this, we have to depend on these drugs. And I think Shirish has also mentioned, and I also mentioned, the future is of a dual pathway approach rather than double antiplatelet drug. That's the answer which we all should remember. The next question is also by Dr. Pancholia. Why is asking so many questions? I don't know. How to optimize triple and then dual therapy in atrial fibrillation patient undergoing PCI. What is the ESC guidelines, Dr. Pancholia? Girish, you want to respond to this?
Yes, Dr. Pancholia. This is an important area where I think you and I run again and again. Patient is known AFib, he may be already on NOACs and he needs a PCI. So the immediate post PCI first month, you need to sort of classify whether he is a high risk for bleeding or average risk or low risk for bleeding. So if it's average or low risk for bleeding, as I said, try and give triple therapy, that is NOAC plus aspirin plus whatever P2Y12 inhibitor you choose. So continue this for 6 months and after that you stop aspirin and go on from 6 months to 12 months on NOAC plus one of the P2Y12 inhibitors that you have used in the earlier 6 months. And beyond 6 months, the patient is only on NOACs. This is primarily for atrial fibrillation. So he'll be on full dose of whichever NOACs you choose, atrial fibrillation dose. So this is low risk for bleeding. Now, who are the high risk for bleeding? Elderly patients, say somebody who is 75 and above. Frail patients, patients who have kidney issues, patients who have previous history of bleeding. These are the overall high bleeding risk patients. And you are anyway using oral anticoagulation, so they all fall into a high bleeding risk patient. So here, triple therapy should be only for first 1 month. From 1 month onwards, you can continue up to 6 months on the P2Y12 inhibitor, like say you're using ticagrelor along with the NOACs. And then at the end of 1 year, you would have them only on monotherapy. So this is how I would put it. Generally, as I told you, 2 studies, the Twilight as well as the Tikoff from Korea, they are sort of running down the importance of continuing aspirin. Aspirin adds to the bleeding complication, but does not improve the ischemic risk. I think this will become more and more obvious to us because this is my personal clinical experience too. And my feeling is slowly the aspirin would go down. So this is answer which is close to the ESC recommendations.
I think it's a very nice and brilliant question by Dr. Pancholia and a brilliant answer by Shirish MS Hiramat. I think the message is very clear, Dr. Pancholia. And I think Shirish Hiramat has given very, very categorically. He does not believe in a long-term aspirin therapy. The message is long-term we need a NOAC beyond 6 months or 1 year. And I think you mentioned very rightly, initially we'll give both dual antiplatelet drugs, but subsequently in some group of patients we give aspirin. He used the word anybody beyond 75 and there is history of bleeding, we have to be very, very judicious. And we should individualize our patient with underlying CKD. And I think the monotherapy, low dose, is the future. I think I totally agree with Shirish Hiramat. The next question is, how do you give dual antiplatelet after PCI? Dr. Anuradha from Chennai. Shirish, again for you.
I think the guidelines as well as clinical practice is pretty similar, steady for last some years. Whenever there is an ACS for which PCI is done, the choice is always between ticagrelor or prasugrel. For first 1 year, we always give aspirin during this period. So if it is ACS, I think this is the way we will go. if it is a stable case and you have done PCI, the aspirin still holds true for many. But I would feel, or even for guidelines for that matter, but I would feel that if you have done a complex PCI where stent thrombosis is going to put the patient into very critical position, I would still not use clopidogrel, because there is a clear entity called clopidogrel resistance. Many studies have shown that even if you make a study as to how much is the platelet inhibition, the accuracy of these studies is just around 60%, and the ESC in 2018 has downgraded the platelet inhibition studies. So we don't really have to worry about these when we are in the first year. You can give ticagrelor very confidently. De-escalation is a possibility. Like if you are really worried about somebody who is high risk of bleeding and you do not want to use the more potent antiplatelets like ticagrelor or prasugrel, you can de-escalate at the end of 1 year, and then you can switch them onto clopidogrel and aspirin. So this is a standard way in which you can de-escalate.
So ladies and gentlemen, to conclude, I must say with a great confidence of my consciousness and heartfelt thanks to all the speakers. The message is very clear, whether it's an echo navigation, or it's a Novak navigation, or a statin navigation, or an antiplatelet navigation, or an anticoagulant navigation. Our objective is vascular health. And vascular health is of paramount importance. But without atrial fibrillation or with atrial fibrillation, with PCI or without PCI, in a acute setting, ACS or in CCS, we should be very clear how to manage this patient. And I think age factor is also of a great importance. Anybody who is young, less than 50, how to manage, and anybody who is above 50, how to manage. We should know. And of course, when in a clinical setting patient come to us, don't follow so-called guidelines, which are only sidelines. They are not guidelines. We have to understand that every patient has to be treated very meticulously on individual criteria as to who is suffering from what and can manage the patient. Navigation of every vascular health and atrial fibrillation is necessary. I express my heartfelt gratitude and thanks to Professor Naveen Sinanda, all the way from USA, from University of Alabama. And I think I'm very grateful the way he expresses, the way he starts this echo, right from the basics of MO to 2D to Doppler to color Doppler to transthoracic to transesophageal and to go to 3D echo. It was a very beautiful demonstration of navigation of echo in atrial fibrillation. You've seen Novak, I've given you the description, very, very clear, how to choose the agent. And I think a navigation of coronary artery disease very nicely expressed by Girish Hiramat. And his focus on statins, high dose, and his focus on antiplatelet drugs, how we should choose, what we should choose, when to give prasugrelor, when to give ticagrelor, and when to give aspirin, when to give a dual antiplatelet therapy, and when to give a double pathway therapy should be very well understood. And I think if we manage our patients, I'm sure we will definitely reduce the morbidity and mortality. The academic partner today is Ipca. I express my gratitude to all the team of Ipca, led by the president of Ipca, Dr. Anil Parikh, who is here with us all the way and who is attending the whole meeting from beginning till end. I am very grateful to you, Dr. Parikh. I am also grateful to Vice President Mr. Johnny Edwin of Ipca, who really worked hard right from the inception to the execution and the outcome of this patient. This was not an easy subject. According to me, it was a tough subject. And I think the consensus is very clear. I'm very happy working with MS Hiramat because I find no controversy here. I told him last time also in the consensus statement and during the COVID. So that's the best thing I like here because I find him a very, very cordial person and a very, very thorough gentleman. And I really enjoy interacting with him and I like his presentations to a very large extent. In the last, ladies and gentlemen, before I hand over the mic to the President of Ipca or to the Vice President of Ipca, I would just like to have a little quote which I always love of Albert Einstein. Albert Einstein said, "Life is like riding a bicycle. To keep your balance, you have to keep on moving." This is what the life is all about. If you really want to prevent clotting, you have to keep on moving. Whether you move by physical, psychological, mental, or by medical interventions. What do? We just clotting in coronaries or other vessels. We have to keep on moving it. How do we move? By anticoagulants, by heparin, or by intervention like PTCA or stenting. And I think this is what he thought long ago, Albert Einstein, that moving is the answer to keep a balance. Thank you very much. We really enjoyed this important dialogue, so-called clinical echo dialogue, and I think addition of comprehensive preventive strategies was really lovely, and I really enjoyed. I express my gratitude to each and every one of you from the core of our heart. Thank you, and I hand over the mic to Anil Parikh and Johnny Edwin. Thank you.
Thank you, sir. So thanks a lot. I think it was a very, very thorough session with knowledge from the stalwarts like Professor Naveen C. Nanda, Dr. H.K. Chopra, and Dr. Siri Siramat. It was really, I hope the participant must have learned a lot. I think I learned a lot today. So it was really great, and I must express my sincere gratitude to all the three panelists, star panelists, with very excellent deliberations. And thank you very much. And I think goodbye to that. And
thank you, Shirish. Special thanks to you. Thank you, Shirish.
No, Dr. Chopra, you conducted it very well, very dignified, and your talk was outstanding.
God bless. Thank you very much. Thanks. Thank you very much. Thanks.
Thank you.
Thank you.
Thank you, sir. Thank you. Thank you.
Recording has stopped. Recording has started.